Beautiful. Well, thank you for joining us for a discussion on challenging retina and optic nerve masqueraders. I'm Jessica Steen, an optometrist in Fort Lauderdale, Florida, and I'm joined by my friends and colleagues, Dr. Carolyn Major and Dr. Danica Morelli. Thank you both for joining.
It's a pleasure to be here.
Now, I think this is something that is so relevant to clinical practice, whether you're in a primary care setting or in a more specialized environment. These challenging cases where retinal or optic nerve disease can sometimes mimic other ophthalmic pathology. And really, this is where we dig into not just our careful clinical examination, but our use of diagnostic imaging technologies and a careful evaluation and understanding of that patient's history, which sometimes can drive us in another direction which we may not have anticipated. I think the other key feature as we walk through a variety of cases is really to understand that sometimes our thoughts and our understanding become more clear or change over time based on additional imaging features and based on additional data. We're also going to work to identify those maybe red flag features on clinical examination or on imaging that may help us to distinguish these masquerade conditions. So let's look at this woman who's a 67-year-old female, and she has a history of primary open angle glaucoma in the left eye, which was diagnosed in 2022. And she had presented taking latanoprost in both eyes and managing well on treatment. Her pressures at this first visit were 16 and 17 millimeters mercury with average central corneal thickness. And one of the questions that we always ask ourselves is this good for this patient? We can look at the clinical features, but a pressure in the mid teens with an average central corneal thickness in a woman in her mid to late 60s sounds quite reasonable related to her glaucoma diagnosis. Looking at the optic nerves, really our attention is drawn to the left optic disc. It is larger than the right optic nerve. There's asymmetric parapapillary atrophy inferior temporal, along where it looks that the inferior temporal neuroretinal rim in that left eye is thin. Now, if we look at retinal nerve fiber layer imaging, once again, our attention's drawn inferior temporal in that left eye. There is focal retinal nerve fiber layer loss that correlates or extends into the ganglion cell interplexiform layer loss that respects the horizontal midline. This is what we expect in glaucomatous optic neuropathy. Her optic disc area is in fact large in both eyes, but again, larger in the left eye than in the right eye. When we look at the retinal nerve fiber layer overall in the right eye, while there are areas that depart from an expected normative range, sometimes we refer to that as a split bundle defect. And when we look at the patient's actual retinal nerve fiber layer and vascular anatomy, there's no focal loss, superior or inferior, in the right eye that we would expect to see in glaucoma. Now, interestingly, she does have a small pocket of ganglion cell interplexiform layer loss that's missing, that extends from really this papillomacular bundle in the right eye that is atypical and unexpected in glaucomatous optic neuropathy. Now, visual fields right and left eye, this is a 24-2C, see to faster in each eye. One other piece, especially in glaucomatous optic neuropathy or other neuro-ophthalmic disease, I love to keep the foveal threshold sensitivity on. Now, this was this patient's first field with us, and you can see the foveal threshold sensitivity in the right eye was depressed. Not what we would expect for her 20/20 acuity. This was just a learning curve for her to figure out, which she quickly realized in the second eye. In the left eye, there are a couple of missed points, superior in the superior hemifield, which were repeatable. Now, again, if we're thinking about structure, we're thinking about function, we have inferior temporal retinal nerve fiber layer loss, ganglion cell interplexiform layer loss in the left eye, and superior visual field defect in that eye. So is this good? Well, a pressure of 16 and 17 on treatment. So now this is really where we go back and think about past data and incorporate past data. Her peak untreated intraocular pressure had been described as 18 millimeters mercury in each eye. So now, is this our 25 to 30% pressure reduction that we would expect on a prostaglandin analog? It's not. Now, did we just miss her peak untreated pressure? Maybe this is related to adherence or poor adherence, or maybe this is a prostaglandin analog non-responder. Her blood pressure in office is 115 over 80 millimeters mercury, which she is on treatment for. She does have a complex medical history. She had a stroke and a transient ischemic attack a year later. She has had bilateral hip replacement at a relatively young age and has a fibromyalgia diagnosis. So when we think about this case and we say, is this patient doing well? You know, is this someone who's not responding to treatment? So, let's take a medication holiday. Let's pause and let's determine if this is someone who truly is a PGA non responder or may benefit from another therapy. And when she comes back 1 month without medical therapy, intraocular pressure is about the same or technically even a little bit lower than where it had been on intraocular pressure lowering medical therapy. So this makes us go back and think, yes, this could be true normal tensive disease, but is there anything else here that drives us in a direction other than glaucomatous optic neuropathy? So when I look back at her past data, she was seen by a very astute colleague, and there were photographs taken. So even in the time where we all use advanced technology, a fundus photograph and evaluation of that data over time can truly go a long way. In 2017, she had presented asymptomatically with bilateral cotton wool spots. Now, this is blockage of axoplasmic flow at the level of the axons of the nerve fiber layer. So, what happens when those cotton wool spots resolve? Well, often they take out the axons with them following the pattern of ganglion cell axonal projection of the retina or through the retina to form the optic nerve. So, what happens when cotton wool spots resolve? They leave this trough of retinal nerve fiber layer defect behind. So now, knowing what we do now, based on this past event in 2017, let's put these pieces together. Could this be glaucomatous optic neuropathy, or could this just be findings related to a past event? Again, we think about glaucoma as a condition of asymmetry, and there is asymmetry here. The right retinal nerve fiber layer overall really is robust and symmetric, with that atypical area that is not consistent with damage that we expect in glaucoma of the ganglion cell interplexiform layer of the right eye. So let's look at this left eye more closely. Now, before we do so, what about that pocket of ganglion cell interplexiform layer loss? Remember that the ganglion cell interplexiform layer data is derived from the macular cube scan. This is valuable information. So this is where I'll jump to the data itself to determine where is the pathology or where is that gap that has been identified, and is there retinal pathology that's causing that ganglion cell interplexiform layer defect? And in this case, there's no obvious or frank retinal pathology in that location. We can look at this in cross-section as well, again, as the data that is used to develop the ganglion cell interplexiform layer scan is developed from the macular cube data. So if we put this together in this patient's left eye, cotton wool spots in 2017 that have now, of course, resolved. And if we look at the axons that were impacted at that time and what's left behind, this trough of retinal nerve fiber layer defect without a clear notch in the neuroretinal rim on this side, could this just be previous or past ischemia and not glaucomatous optic neuropathy? We think about other conditions that cause these retinal nerve fiber layer defects that look like glaucomatous damage. Any form of retinal ischemia, whether that is in diabetic eye disease and hypertensive disease, or in systemic inflammatory disease, for example, in lupus, optic disc drusen, or sometimes even non-arteritic ischemic optic neuropathy can cause this pattern of retinal nerve fiber layer defect. But when we put this piece together, these pieces together, what differentiates glaucomatous optic neuropathy from these past events that have occurred? And that's ongoing change over time. So in this particular patient's case, when we took and look at her entire risk profile, I think this is someone who overall has a low risk profile for development of glaucoma. I paused her medications. This is someone that I'm watching every 3 months at this point with the goal of extending time between visits. And I am looking for stability. I don't believe that this patient has glaucoma, so therefore I do not expect change. However, I'm still monitoring closely in case this patient also develops glaucomatous optic neuropathy. So sometimes these challenging cases that even the structure and function fits, but that past information really causes us to change how we approach management of these cases.
This was such a great case, Jess. I'd love to see what the OCT in geography would look like because, kind of most spots, that whitish, like opacity of the retina eventually resolves, say within a month or so. But then on OCT in geography, you have like a permanent footprint of capillary non-perfusion on like the superficial capillary plexus that could have helped clue you in, like, oh yeah, that this isn't glaucoma. This is actually some retinopathy problem.
That's a great, great point. All right, let's look at one more case. This is a 54-year-old male. And here's his ocular history. This is really how we describe or we think about evaluation of past data. He has been described as being suspicious for glaucoma. 25 plus years ago, reports that he had been recommended to perform pencil push ups due to a lazy eye. And something that he was very specific about was an episode or multiple episodes of vision loss. He says he was never told why. He described it to his primary care physician, but he was never given an answer. The vision came back, but it happened and lasted for about 3 days to a week. And one time it affected the right eye, the other time it affected the left eye. And this was about 5 years prior. So, as we're starting to think about why that could be or what that may have been, this is very different from what we expect for someone who, for example, reports amaurosis fugax, which generally lasts for a much shorter period of time. This gentleman was adamant that it was at least 3 days that this vision loss lasted for, and that he had complete recovery of his vision at that time. He has no double vision, despite this report of a previous lazy eye. Now, systemically, he has sickle cell trait, hypertension, and has a broken bone or had a broken bone in his right foot. But he reported that a couple years ago, he had just a change in his walking pattern. He said that exercise became more difficult and then walking became more difficult. And this was something observable from the waiting room into the examination room for a young, fit man. He did struggle with comfortably moving from one place to the other. He also reported that he has stabbing or shooting pain, especially down the right side of his body and the right side of his hand and down his arm. Now, he had been referred to neurology and he was currently under investigation by neurology related to the discomfort on the right side of his body and this change in gait. Now, he was suspicious of glaucoma secondary to disc appearance, and his vision was 20/20 in each eye, but he did have a subtle afferent defect in the right eye. Pressures were 14 and corneas were thin. When we look at his optic nerves, if we're thinking about focal neuroretinal rim loss, where our attention goes first is to the left eye. That's not the eye with the afferent pupillary defect. There's no clear notch in the neuroretinal rim, but the rim does look thinner inferior. Maybe that's also because it's a slightly deeper cup than on the right side. But when we look at these two optic nerves side by side, there does seem to be a coloration difference, and there was subtle optic disc pallor of the right optic nerve. Again, sometimes it's challenging to see at the slit lamp. Sometimes a photograph and comparison between the two eyes really does go a long way. Now, retinal nerve fiber layer imaging, right and left eye, not consistent with what we would expect in glaucomatous optic neuropathy. He does generally have this shift of where the thickest retinal nerve fiber layer bundle is, more especially in the left eye, really 12 o'clock and 6 o'clock, away from where the device would expect based on a normative or representative group of individuals. On the right eye, superior temporal is where the retinal nerve fiber layer departs from that normative range. And when we look at his ganglion cell interplexiform layer in the right and left eye, it is significantly depressed. This is not a pattern that we expect in glaucoma. Remember, 20/20 acuity, afferent pupillary defect in the right eye, and essentially flat ganglion cell interplexiform layer in each eye. Now, once again, I always will go back to the macular cube data to ensure that there isn't existing or coexisting macular pathology that's leading to that abnormal ganglion cell interplexiform layer. We can look at the ETDRS overlay, the overall thickness overlay, and again, we're not seeing any obvious pathology despite that near flat or significant loss of ganglion cell interplexiform layer in both the right eye and symmetrically in the left eye. Fields were challenging for this gentleman. This was his first field. Foveal threshold sensitivity lower, once again, in the right and left eye than what we would expect for someone who is 20/20. Holding the clicker in his right hand was uncomfortable, so he had held the clicker in his non-dominant left hand. Again, when we're looking at the overall pattern, there is generalized depression, maybe some inferior loss that outweighs the superior loss in the right eye, but not a characteristic or typical expected pattern in glaucomatous optic neuropathy, and not something that is reflected by the optic disc appearance or the retinal nerve fiber layer ganglion cell interplexiform layer data. So, this patient is under investigation with neurology, and this is where a phone call to his neurologist really came into play to better understand what his neurologist and neurology team was investigating for, because this is not a glaucomatous appearance. But if there's underlying neuro-ophthalmic disease or neuroinflammatory disease, that could cause, of course, changes to the retinal nerve fiber layer, ganglion cell complex, and visual field. Here's the MRI of the brain. This was a 3 Tesla device read by a neuroradiologist. And what was determined was really described as textbook characteristic features of white matter lesions throughout the brain, with characteristic features of consistent with demyelinating lesions and multiple sclerosis in this gentleman. Now, typically we think about multiple sclerosis as a condition of young white women, and while females do outweigh the number of men who are diagnosed with multiple sclerosis, we do certainly have to keep in mind that reporting and access to care differences, especially, I won't just say historically, but in the near recent past, between individuals with different racial and ethnic backgrounds has impacted reporting. And what we understand is that multiple sclerosis is nearly as common in African American individuals as in white individuals. However, the diagnosis is still far more common in women as opposed to men. So if we look at this patient's risk factors, overall, his risk factors for glaucoma, this is an African American man in his 50s. He does not have elevated intraocular pressure, but does have a thin central cornea. But in this particular case, this is someone who has underlying neuro-ophthalmic disease, and realistically, what he was describing now, as we're putting these pieces together, sounds consistent with an optic neuritis episode in each eye in the past, rather than glaucomatous optic neuropathy. Once again, we're thinking about the typical patterns that we expect to see, and here are the differences. This overall depressed ganglion cell interplexiform layer that's diffuse in the right and left eye, and no focal retinal nerve fiber layer defect in either eye. Really, in this case, it seems as if more so that this patient doesn't quite fit the mold of the normative or reference database as to where the retinal nerve fiber layer is expected to be thickest, almost this shift of the retinal nerve fiber layer thickness bundles. So another case that, really makes us rethink everything, 2 optic nerve cases. Danica, Carolyn, any other thoughts on these?
That was such a great case also, Jess. And I think the history was like so clutch there. There's no patient with glaucoma, unless maybe it's somehow to like intermittent angle closure is going to complain of like vision loss for 3 days that then recovered. So I think that was a really good pickup on your point.
And just a good reminder of this is a patient who is a very clear historian, but he didn't offer that information. This comes from really careful discussion. Any particular episodes or instances of vision loss or double vision, which, he was more than happy to share once he knew what we were interested in.
The first case I'd like to present is an 81-year-old white female who presented for a second opinion regarding a diagnosis of normal tension glaucoma. She'd been diagnosed with normal tension glaucoma in the left eye and was called a suspect in the right in 2022, and she was treated with bilateral latanoprost. She was tolerating the treatment without a problem, but her main concern was that the vision in her left eye just seemed much worse than the vision in her right. Her treating ophthalmologist felt like she would benefit from a YAG capsulotomy, but the vision didn't improve after the YAG. On exam, her vision was 20/20 in the right and 20/40 in the left. Red cap desaturation was 60% in the left eye compared to the right, and her color vision was really dramatically reduced in the left eye as well. Not surprisingly, she had a mild APD in the left eye, and her motility was fine. Slit lamp exam was unremarkable with no secondary signs of glaucoma, and her intraocular pressure was 15 and 16 on latanoprost. I don't have a picture of her optic nerves. When I looked at her nerves, she had a mildly large CD ratio for the size of her disc, but no focal rim thinning of either nerve. And of note, the left eye had mild temporal pallor. These are her visual fields, and you notice certainly on the left eye that we have a temporal or left-sided visual field defect, which is not consistent with the diagnosis of glaucoma. I'll admit that initially I kind of ignored the right eye and wasn't really concerned, but when I saw that the left eye seemed to have a temporal defect, I went back and looked at this right eye and wondered if this might be a highly asymmetric bitemporal visual field defect. When we looked at her RNFL, you'll notice that the RNFL in the left eye is significantly reduced compared to that of the right, but it doesn't really have the right pattern for glaucoma. So in glaucoma, we expect to see loss superiorly or inferiorly or both. But in this patient, what we really see is loss in the papillomacular bundle, which again, is just not really consistent with the diagnosis of glaucoma. When we look at structure function together, we see that the RNFL in the left eye is thin pretty diffusely, but especially in the temporal area compared to the right. And again, we have this temporal visual field defect in the left for sure, and maybe a subtle temporal defect in the right. So when we put all those things together, certainly the diagnosis of glaucoma is really in question. I decided to order an MRI of her brain and orbits with and without contrast to see what was going on. This is the initial brain MRI report. And the first thing that I notice is that the cella is partially empty. So we know that something is going on with the pituitary near the chiasm. Something's not quite right when the cella is empty or partially empty. They also noted thickening and enhancement of the dura in the cella and extending into that left optic canal, most characteristic of a meningioma, but certainly recommending that other types of more aggressive tumors be considered. When we looked at the orbital MRI report, they made an addendum and said a very small tuberculin meningioma can be seen. So from this, the patient was sent to a neurosurgeon, and the neurosurgeon fully evaluated the patient and gave her the option of surgical resection versus close observation for change, given the fact that she was 81 and that meningiomas are benign and typically slow growing. So we will see how she does. She did not opt immediately for surgery. You know, when I see a case like this, I always think about what I can learn from it, how I can be better next time, how I can help my students understand what's going on and when to be really suspicious. And the first thing I think about with this patient is just listen to your patients. You know, our patients kind of tell us what's going on. And this patient came in with a very specific vision complaint. And most patients with glaucoma, certainly patients with early glaucoma, don't really complain of vision loss. And she came in and essentially handed me this question about whether or not this really was glaucoma. That prompted me to do two very simple tests in the office, red cap desaturation and color vision. And I don't do those tests normally on my glaucoma suspect evaluations, but because she was specifically complaining about her vision and because her vision was reduced, it made sense to do those two tests, which take, probably less than a minute to do and really help bolster this idea that this is something other than glaucoma. The second thing that I think is important to remember is that glaucoma can be asymmetric, but it always looks like glaucoma. And let me kind of unpack that a little bit. I think that it's not surprising to me when a glaucoma patient has an APD, right? Because you can have really asymmetric glaucoma and that pupil will have an APD in the worst eye. But glaucoma always looks like glaucoma in that we see thinning of the neuroretinal rim. We see nerve fiber layer loss in the area that we expect, the superior or inferior bundle. And we see visual field defects that are either paracentral or nasal step or arcuate defects. And while you can have a temporal defect in glaucoma, it's not very common. So this really just didn't look like glaucoma. Also going back to that optic nerve is just so critical. I think, this is really an example where we did imaging and it showed us loss, but what really was helpful was looking at the actual optic nerve. And then finally, I think specifically related to normal tension glaucoma, about the things that ought to kind of get your spidey senses up and make you think maybe this isn't glaucoma. And those things are when a patient's visual acuity is reduced, when their color vision is reduced, when you see pallor of the optic nerve like we did in this case, rather than cupping, and then when you have visual fields that respect the vertical midline. Those are kind of forewarning signs that maybe this really isn't normal tension glaucoma. The second case I want to present is a 75-year-old white female who I sort of inherited as a patient after a coworker of mine retired. This patient had a 1-year history of latanoprost use for primary open-angle glaucoma. She had RNFL and macular ganglion cell thinning and corresponding visual field defects that really did look a lot like glaucoma. Prior to treatment, her IOP had ranged from 16 to 20, but I will say that, her packs were really thick, which means that probably she wasn't really getting anywhere close to an IOP of 20. On exam, she had 20/25 vision in her right eye. That was due to a little nuclear sclerotic cataract, 20/20 in the left eye. Pupils, motility, confrontation fields were fine in each eye. And again, her slit lamp, like the previous patient, really was pretty normal, didn't show any signs of secondary glaucomas. Her IOP was 14 in each eye, and again, this was on latanoprost. When we look at her fundus, we don't really see anything that looks dramatically like glaucoma. And when we look at the optic nerves, certainly we don't really see the cupping that we would expect to see with glaucoma. But when we look at her imaging, she really has RNFL loss and ganglion cell loss that's pretty consistent with a diagnosis of glaucoma. So we have that inferior bundle RNFL dropout in both eyes, and we have inferior temporal ganglion cell loss that's pretty consistent with the diagnosis of glaucoma. When we stitch those together using the PanoMap, which really just kind of combines the RNFL scan with the GCIPL scan, we see that those really correlate very nicely and form almost a continuous band of loss inferiorly in each eye. It's not surprising that we see a superior arcuate defect in each eye. It matches very well with the structure. And yet the question still is this really glaucoma or is this something else? When I looked at her guided progression analysis over the period of about 4 years, what we see is just absolute stability in both eyes of her RNFL. She was only treated for about 1 year of this time period. When we look at her ganglion cell thinning, we see the same thing. Even though it's really thin inferiorly, there's been no progressive loss over the period of about 4 years. So what's going on? Why does she have this very stable RNFL and ganglion cell loss? We went back to the structure and looked with fundus autofluorescence. And we could see very obvious now optic nerve head drusen that I think if you go back to the pictures, you probably can see, but it wasn't super clear, super obvious in the fundus exam that she had these drusen. But when we do fundus autofluorescence, suddenly they just light up like Christmas trees. And we know that optic nerve drusen can cause RNFL loss, ganglion cell loss, and visual fields that look exactly like glaucoma. These tend to be stable, although they have been reported to be progressive in some patients. And so when you have a case like this where you have progressive loss, it can be really challenging to sort of sort out what is this? Is it progressive glaucoma? Is it progression of the optic disc drusen? Are they migrating or moving in that optic nerve? But in this case, she was really, really stable. So what do we do? Is it glaucoma? I don't think it is. I think everything that she has is related to these optic disc drusen. Does she need treatment? I would argue that given the stability of everything that we see, her visual field and her imaging, that she doesn't need to be treated, but she's already being treated. So how do you handle that? How do you don't want to throw the previous doctor under the bus. You could argue that it's not bad for her to be on IOP lowering as long as she's tolerating it well. But I sort of really hesitate and dislike having patients on medication when they might not need to be on it. So really the way that I handled this was just to explain what I saw, to tell her that I thought that what she had was not really glaucoma, but was this optic disc drusen, and they really appeared to be quite stable. And we could either continue to treat her to lower her pressure, or we could try discontinuing the treatment and watching her to see if she remains stable over time. And even though she wasn't having any trouble using the latanoprost, she was very excited to be able to stop using it. So now looking at her scans over an even longer period of time, it's been about 4 years since she discontinued treatment, maybe 3 years. We see that the RNFL and in both eyes and the ganglion cell in both eyes has remained very stable, as has her visual field loss. So this is a case where our imaging actually could be consistent with glaucoma, but the appearance of the optic disc is really not. And so looking at that optic nerve is really, really important in making a diagnosis of glaucoma versus something else.
Danica, that was such an excellent case, really highlighting how multimodal imaging can look for disc drusen in patients that can mimic glaucoma. And I want to also share the utility of especially enhanced depth imaging, raster OCT scans through disc drusen. I love when patients I love doing imaging when patients have disc edema, especially like a radial raster scan on the optic nerve head to try to look for subtle disc drusen features. And we know that disc drusen on high resolution OCT imaging have a signal poor core, so they're like dark ovoid type of structures that tend to have a hyper reflective margin around them. And of note, they do not tend to cast a posterior shadow. So sometimes we can confuse these large retinal blood vessels as disc drusen, but they cast shadows down below, whereas true drusen do not cast shadows. So it's kind of like a good, I think, just clinical tip when you're trying to identify disc drusen on OCT. And another, pretty prominent feature of disc drusen on raster imaging can be these horizontal hyperreflective bands, which is some sort of artifact that occurs from the disc drusen. Sometimes I've seen patients where I can't even see the disc drusen, but I can see these horizontal hyperreflective lines that really clue me in that, oh yeah, this patient likely has some disc drusen. And then I'll go on and usually do a B scan to confirm.
Carolyn, is there a reason why you prefer the radial scans versus, for example, a 21 line raster as you're imaging the optic nerve in cross section?
Yeah, I think it just gives me better imaging with regards to like different angles in that margin of the optic nerve head where I'm trying to look for, maybe some subtle subretinal or peripapillary fluid that would be suggestive of true, disc edema or papilledema as opposed to, say, disc drusen. So this case is a 36-year-old Native American female. She's actually a new patient to us in optometry who was presented initially in the ER um, complaining of progressive blur and sort of a static vision type of appearance in both eyes that's been worsening over the past month. She was also complaining of a headache and photophobia for about the past week. So the ER saw her, they diagnosed her with migraines, they gave her some Tylenol and Benadryl and a, saline bolus, and then said, go over and see our friends in optometry. At that ER visit, they had already performed a CT and a CTA scan of the head and neck, which was within normal limits. When she comes to see us, her vision is severely reduced in the left eye more so than the right, with her acuities being 20/50, pinhole no improvement in the right, and the left eye 23/50, which did pinhole down to 21/50. And we looked at her anterior segment examination. There were some 1+ cells in both the AC anterior chamber of both eyes, as well as in the vitreous of both eyes. And then she had some features consistent with like chronic anterior uveitis, which was posterior synechiae worse in the right eye than the left. Fortunately, her pressures were within normal limits, and her blood pressure was good here as well. When we look at her Claris wide field color fundus photography, we can see that this disease looks relatively symmetric, that's affecting both eyes, and that we have some really severe subretinal choroidal thickening that's resulting in these pockets of subretinal fluid, of which are numerous and tend to involve or are involving the macular region of the left eye here. You can also see that there's some chorioretinal pigmentary changes, especially like right here and right here in the mid-peripheral region of the right eye. Here's just a magnified view of the posterior pole, highlighting these blisters of subretinal fluid that are more extensive in the left eye, as well as we can see these retinal striae, both in the macular regions, as well as in some of the peripapillary regions. And that choroid thickening is so severe that it's causing some swelling of the optic nerve head and indistinct disc margins. In Zeiss Forum Retinal Workplace, I've overlaid our 21-line raster scan on top of the color fundus photography, and we can see there's really extreme choroidal thickening to the point where we can't even identify the posterior choroid here, but my guess is it's very, very thick. And it's caused this lumpy, bumpy contour of the RPE, or like these RPE folds and undulations. And on top of that, when we have compromise of the RPE, we have fluid from the choroid that can exude into the subretinal space. So we can see this pocket of subretinal fluid right underneath the foveal region. And then this thickening of the choroid is casting the retina into these folds. And we see these undulations or these like striae that are occurring actually in the internal limiting membrane region. Here's some other cuts through the macular region where I really wanted to highlight this septae, where we think in what this is VKH, choroidal thickening, is that the fluid actually accumulates and splits the outer and inner layer of the photoreceptors that kind of creates these ring-like pockets of fluid, and that this fluid tends to have more activity. So we tend to see particulate matter actually within this fluid of the septae. And then here I'm just highlighting for you this big pocket of subretinal fluid that's inferior to the optic nerve head here in the right eye. As we can see in her left eye, this is the raster OCT again, overlaid on top of our color fundus photography in Zeiss Forum Retinal Workplace. There is extreme choroidal thickening with these RPE undulations and folds. She also has this large pocket of subretinal fluid. I mean, the macula literally looks like a mountain when I first saw this OCT scan. And then this large septal space where we have the outer photoreceptors separated from the inner segment of the photoreceptors. And in this septal space, we have some particulate matter, probably some inflammatory cellular debris. And so I want to kind of go through our differential diagnosis at this point. We have anterior chamber cells, we have vitreous cells, we have choroidal thickening, as well as subretinal fluid. So this is likely some sort of bilateral panuveitis. And the features of the choroidal thickening, as well as these exudative retinal detachments, are pretty characteristic of VKH. I think some other differentials to consider would be like uveal effusion syndrome, posterior scleritis, some sort of choroidal infiltration like lymphoma, leukemia, choroidal metastasis, potentially central serous, right? Or some sort of pachychoroid disease, white dot syndromes. I think all of these things or these masqueraders kind of come into play, and we need to do some thorough systemic evaluation, of course, in every case of panuveitis to rule out masquerading syndromes. So just to kind of compare and contrast, one of our differentials was going to be choroidal infiltration by a tumor. And this was a patient that had breast cancer and unfortunately had a choroidal metastasis, well, several of them, unfortunately. And we can see in the choroidal metastasis how the RPE tends to take on that lumpy, bumpy contour, very similar to what we visualized in VKH, as well as have exudative subretinal fluid, and subretinal fluid that sometimes cause the splitting of the photoreceptors and hyperreflective exudate sheets in the subretinal space. Pseudopanuveitis is inflammation of the entire uveal tract. We have anterior chamber cells, vitreous cells, and some sort of posterior inflammation, whether it's optic nerve swelling, whether it's choroiditis like our case. Certainly this is a case of panuveitis, of which there are many, many, many cases. And all panuveitis, whether it's unilateral or bilateral, always deserves a very thorough systemic evaluation. So we want to look for potential infectious causes like syphilis, TB, or tick-borne illness. We want to think about other masquerading syndromes such as sarcoidosis and VKH being another masquerading syndrome that's highly likely in this particular case. We know for VKH there are some HLA-associated markers that can be present, especially HLA-DR4. Unfortunately, we didn't have that lab testing available where I saw this particular patient, but we were able to hit almost all of these other labs for other infectious and inflammatory etiologies. So our diagnosis in this case was panuveitis both eyes, likely secondary to VKH, we suspected. At that point, we're going to take a step back and ask her about systemic signs and symptoms of VKH. So any vertigo or whitening of the skin, any whitening of the eyelashes or hair, any hearing problems. We know that there's meningeal signs that accompany VKH as well, and she was complaining of this headache, which is why she originally went to the ER. So it does seem that the headache could be correlated to VKH, which is what we suspect, but she denied any other systemic symptoms or signs of VKH. We ordered all those panuveitis labs. I started her on topical only prednisolone, 1 drop every 2 hours in both eyes, as well as atropine 3 times a day in both eyes. I'm going to withhold the oral steroids until we get confirmation that this is not infectious. And I think that's so important. You kind of look at this retinal presentation, you're like, oh my gosh, it's so severe, it's so bad, I got to throw a bunch of steroids on it. But you don't want to throw steroids on, say, like syphilis, some sort of infection, because that's going to make that condition worse. So I'm going to wait to get my lab testing back, have a firm negative on TB, syphilis, tick-borne illness, as well as HIV before I start oral steroid therapy. She actually had never had she said even just like a primary care examination or any sort of lab testing done in her entire life. So really encouraging her to establish a primary care provider so that we could eventually refer to rheumatology, which we were thinking we would likely need. Asked her then to come back for a 3-day follow-up so we could, see how things were going with the topical drops and also review any of the lab testing that had come back. She no-showed that 3-day follow-up, but about 1 week after my initial visit with her, I got back all the lab testing, which was all negative, which would be confirmatory with potentially VKH. So I called her, started her on oral steroid or oral prednisolone, 50 milligrams, 3 times a day, along with a proton pump inhibitor. So here in Zeiss Forum Retinal Workplace, we can also do a macular thickness analysis that allows us to compare and synchronize 3 macular cube OCT scans. So here we're looking at her right eye on baseline, a 10-day follow-up. This actually would have been 3 days on oral steroids, and then 1 month after the initial visit. You see her vision improved from 20/50 down to about 20/25, and we had complete resolution of the serous exudative detachment by that 1 month follow-up, at which point we started tapering the oral steroid. Here, similar in the left eye where we can see this thickness comparison analysis, even 10 days on follow-up, just 3 days on oral steroid, she has this dramatic decrease in serous fluid. this normalization of the RPE contour and choroidal thickness with near complete resolution by 1 month's time, and her vision improved from 2150 down to 2025. Here in Zeiss Forum, we can also synchronize and compare the baseline and 1 month follow-up raster scans, as well as overlay these raster scans on top of the color fundus photography. And again, we can see at this 1 month follow-up visit that she's clear of any subretinal fluid, and we're starting to see this sunset glow fundus appearance, which is characteristic of VKH. Similar findings are present in the left eye where we have resolution of this subretinal fluid, as well as this sunset glow type of fundus appearance at 1 month. Anytime we have any outer retinal choroidal pathology, fundus autofluorescence is going to be our friend, right? Because we're basically evaluating the integrity of the RPE. So here is the wide field Claris imaging on the 1 month follow-up in the right eye, along with the fundus autofluorescence. We can see this sunset glow fundus. So this refers to disc pallor, which I guess is the sun, and then the rest of the sunset being this orangish reddish hue to the posterior pole, especially the macular and peripapillary regions due to thinning and attenuation of the RPE, which has been damaged. You can also see some of this granular hyperautofluorescence on fundus autofluorescence as well. And similar appearance in the left eye, perhaps a bit more severe, where we have this granular RPE changes on our color fundus photography that corresponds to granular hyperautofluorescence on FAF. So VKH is a multi-systemic autoimmune disorder that preferentially targets melanocyte-containing tissues. So in the eye, we have melanocytes in the choroid, we have melanocytes in the RPE, and so this affects not only the eyes, but also the ears. So patients may have tinnitus or hearing loss. They may have depigmentation of the skin, depigmentation or whitening of the hair, as well as meningeal signs. So like headache, nausea, vomiting, like a flu-like type of prodrome is common in patients with VKH. It does have some HLA associations as we discussed. However, there's no definitive specific lab test to confirm a diagnosis of suspected VKH. It's kind of a clinical syndrome that we'd have to put together. It typically affects females more so than males aged 20 to 40 and has a predilection for Asians, Japanese, Hispanic, and our patient being Native American. We talked about some of the systemic findings already, but like a flu-like prodrome, neck stiffness, hearing loss, tinnitus, vertigo, whitening of the skin and hair. And then from an ocular standpoint, it tends to cause usually bilateral and recurrent granulomatous panuveitis. Although our patient didn't have granulomatous type of presentation, she didn't have any KPs or anything like that, she did have this bilateral sort of raging panuveitis with marked choroiditis, that choroid thickening, and exudative retinal detachments. So as I mentioned, the diagnosis of VKH is clinical. There's no specific lab test to test for it, but some of the diagnostic criteria include you have to have no history of trauma because sympathetic ophthalmia would be a potential differential diagnosis to consider. You have to have lab work that is negative, excluding masquerading syndromes like syphilis, sarcoidosis, TB, which is really why I've included the case in the discussion here today. There has to be presence of diffuse choroiditis, exudative retinal detachments, and usually disc leakage on angiography, and then neurologic and or auditory type of findings.
That is an impressive case. I think most impressive was how rapidly that patient not only improved, but resolved with high dose steroids, and excellent use of imaging and retina workplace to not only qualitatively watch that improvement, but also quantitatively be able to measure that improvement, which is something that with other tools, we don't have that benefit easily tracked or graphed the way that we do. Wonderful.
Yeah, that's what I love about Zeiss Forum Retina Workplace is that I can easily see a patient's like hopefully improvement over time or worsening over time. It's so easy to assess for progression. And moving on to our next case, this is a 39-year-old female. She came in for just her routine diabetes examination. However, we saw that there was a reduction in best corrected visual acuity of 20/40 in the right eye, 20/30 in the left, When we looked back at her prior examination 1 year ago, her vision was also reduced at that time to 20/30, and there really wasn't any explanation as to why the vision was reduced. And just looking at the anterior segment, there wasn't any significant cataract or anything that could explain it. Sorry, the thunder here is so loud.
Ooh.
Sorry. Just pause for 1 second. So loud, it's insane. Here, looking at her posterior pole and maculas, again, we're not seeing any diabetic retinopathy or any exudate in the macular region that maybe could be causing decreased vision. So it's unlikely she would have diabetic macular edema, but of course we still want to do an OCT. But like maybe there's a little bit of a reddish hue to the macula, perhaps some RPE modeling. But for the most part, I mean, the fundus is looking pretty good. So it doesn't really explain why is the visual acuity decreased. When we look at in Zeiss Forum Retinal Workplace, we've overlaid the raster OCT scan on top of the color fundus photography. In the right eye, we can see she's missing a central chunk of photoreceptors, so particularly the ellipsoid zone of the photoreceptors. And I'm seeing that there's several different diagnoses that kind of run through my mind here. The top one being really solar retinopathy, the fact that this is dead central, and we know that that causes loss of the ellipsoid zone and ISOS junction, whatever you want to call it, in the center of the foveal region. I think other things to consider when you're seeing a presentation like this would be toxic maculopathy. So especially like prior to tamoxifen use. Usually if it was Plaquenil, it would be more pericentral loss of the photoreceptors. But we asked her about prior to tamoxifen use, Plaquenil, she denied all that. Could this be a pachychoroid type of syndrome? That's definitely something I would consider in any outer retinal RPE disruption. Her choroid morphology and thickness looks relatively normal. And I find often in older individuals too. So, I mean, this is a younger patient, 39, but if she was over the age of 50, certainly when there's RPE photoreceptor disruption, a diagnosis of macular degeneration should always be considered. When we put together also the OCT raster scan findings of the left eye, she has some photoreceptor loss, but it's decentered temporally. And it's this decentration temporal pathology that now starts to, turn in my head and say, I need to think about macular telangiectasia type 2. Because we know in macular telangiectasia type 2, it has a preference to affect the temporal perifoveal region first. In order to visualize these subtle telangiectasias that I suspect may be present, I want to use some high-resolution OCT angiography imaging. So I intently chose to do a 3 mm cube to get the highest resolution detail in the center of the foveal region as possible to detect these early telangiectasias. And we want to look at the superficial and the deep capillary plexus to find those telangiectatic vessels. So here in Zeiss Forum Retinal Workplace, I'm in my angiography analysis, and I've selected the superficial preset. And we can see there's kind of like an enlarged foveovascular zone, some kind of dilated irregular capillaries on the temporal aspect where we would expect MACTEL type 2 to affect first. And then also looking at the deep capillary plexus, some really prominent and irregular dilated telangiectasias in the temporal perifoveal region, highly consistent with macular telangiectasia type 2. Here's the left eye looking at both the superficial and the deep capillary plexus here kind of side by side. And the findings are even more striking here in the left eye, where we have this temporal notch or enlargement of the foveovascular zone, these blunted right angle venules, and then we have these weird dilated telangiectatic capillaries in the temporal aspect of the perifoveal region. So OCT angiography really makes this diagnosis of macular telangiectasia type 2 very clear and noticeable. So the macular telangiectasia type 2 is an idiopathic bilateral neurodegenerative disease that primarily affects the perifoveal capillaries of both eyes. Our patient was on the pretty young spectrum in terms of age that this usually presents. Most patients present when they're around the 5th or 6th decade of life, where our patient was quite young at 39. And so we know she still has a long time to live where this condition could potentially progress. Especially, we think that there is some systemic vasculopathic risk factor association. So, patients with MACTEL type 2 often have diabetes, hypertension, both of which she had, and could aggravate and progress her condition over time. I wanted to highlight the importance of early diagnosis and monitoring of macular telangiectasia type 2 because we now have an FDA-approved treatment option for it, which is fabulous. So in March of 2025, Inselto, which is a sustained release ciliary neurotrophic factor implant, was FDA approved for the treatment of macular telangiectasia type 2. So this is an OR outpatient procedure where we actually suture a sustained release device to the scleral wall, which slowly releases out cilioneurotrophic factor. And in phase 3 clinical studies, has been shown to slow the loss of photoreceptors in patients with macular telangiectasia type 2. And I think in our patient, she's very young, she's 39. She already has some decent changes that we can see on MAC, not only OCT, but OCT angiography of MACTEL type 2. She already has some decreased vision of 20/30, 20/40 from this particular condition. And she has a long life left to live, potentially having progression and further vision loss. The sooner we treat, the sooner we can slow the progression of the disease, the better her visual outcome. So we discussed with her that there is a treatment option, and she opted for a referral to a retina specialist to consider newly FDA-approved treatment options. Other complications that you would want to recognize in macular telangiectasia type 2 and refer for appropriate therapy would be sometimes patients can develop subretinal or choroidal neovascular membranes. Of course, we typically treat that with anti-VEGF therapy. And sometimes the atrophy of the retina can be so severe that it leads to almost like an atrophic full thickness macular hole. And we would treat that the same way as we treat any sort of full thickness macular hole. So the take-home message here really is use OCT angiography in patients that you suspect potentially this is macular telangiectasia type 2. They have some retinal thinning, especially the outer retina, decentered temporally, some decreased vision that's unexplainable. OCT angiography is going to allow you to detect the earliest macular telangiectasia type 2 possible, which we know is now potentially amenable to ciliary neurotrophic factor therapy.
Outstanding and excellent to highlight as we're thinking about which of our patients may benefit most greatly from this currently difficult to access therapy. It really is those early cases. I think this is, really a prime example, and I'm glad to hear that she was interested and curious about pursuing therapy.
Yeah.
I think bringing all of these cases home, it really highlights the curiosity that's needed to dig into those maybe unexpected or uncertain findings or those red flags, whether that's reduced visual acuity when we can't otherwise explain the reduction in acuity, or patterns of retinal nerve fiber layer loss that don't follow what we expect in glaucoma, or clinical findings that don't quite fit with a glaucoma diagnosis. So thank you very much, for sharing, for discussing. It's been a pleasure.